First of all, thanks all you guys for being here to learn about this important topic. And a big thank you for Dr. Paul Hicks for being here. Although Paul and I have been at Scott and White forever, we don't get to see each other much. And maybe that's a good thing that I don't see him, okay? I don't know. His area is different than my area, but I was fortunate enough in December, Paul and his wonderful wife, Susan, came over to the house because we had a thank you dinner for all of the doctors that volunteer at the Temple Community Clinic. And we had a thank you dinner in December, and it was great because I got some one-on-one time with Paul, and I got updated on what he's doing. And Paul was at the dinner because he volunteers at the Temple Community Clinic. Is that not awesome? Yeah. Helping those patients who have mental health needs, and he comes and volunteers. That's just incredible. And we've got a lot of our volunteers here and our medical director. Awesome, awesome. And so I got to talk with Paul, and I said, Paul, what are you up to? And he goes, well, I'm dealing with this and that and resistant depression. And I'm like, what? And he told me about some of the things that he was doing. And I was so excited. I had him and Susan over for dinner the next month. I want more one-on-one time because I am fascinated in why we do what we do. Our thinking drives our life. And all of us can up how we think, which rules our life. And so I'm so glad that Paul agreed to speak tonight. Paul got his medical degrees and his pharmacology degree at Baylor College of Medicine in Houston, and then went off to the West Coast to Stanford to get for his residency in psychiatry. And then he's been at Scott and White now for what, 35 years? We've both been there for 35 years, so that makes 70 together, okay? All right, so Paul, we're really excited about what you have to say. Thank you for being here.
Yeah, thank you. Well, it's a pleasure to be with you all tonight. I would like for us to talk about depression for a variety of reasons, one of which is that depression is something that, if properly treated, people can get better. People can resume their life and go on and be happy again. There aren't too many life-threatening illnesses that you can say that about. And so treating depression is really important. Now, we're going to be talking about it from a variety of perspectives. I kind of anticipated some questions that you might have, and so we're going to go through those one by one, and hopefully in the process of doing so, you'll understand depression a little bit better, and if I can figure out how to work this. So, what is depression? Well, if you look on the internet, you can see people giving autobiographical information about what it feels like to be depressed. And some of you may relate to this. And I think in particular, depression is living in a body that fights to survive with a mind that tries to die. I think that says a lot about depression. The psychiatrists have their own book that we live by, the Diagnostic and Statistical Manual. And when I was in training, we were all the way up to the DSM-3. It's now in the DSM-5. And if I have to guess about what's going to be in the future, when I'm talking about saying, giving students examples of things I think should have been there, I say the DSM-6, but we're still in the DSM-5. And so what it says is that if there is a depressed mood present for 2 weeks that is associated with characteristic findings of problems with sleep, loss of interest in usual activities, increasing sense of guilt, poor energy, poor concentration, a change in appetite. It can either be up or down, a change in psychomotor activity, up or down, and frequently suicidal thought. You need 4 things plus depressed mood to be depressed, and it has to be present for at least 2 weeks. It turns out that about 1 in 5 women in the course of their lifetime will experience depression, and about 1 in 8 men, so that works out to roughly 1 in 6 people in their lifetime will experience depression. So I suspect that in this crowd, there are several people, maybe even most of us, who have experienced some depression in your life. Certainly, if you haven't experienced it yourself, you know someone who's had a very significant episode of depression. In any one year, roughly 7% of the US population will experience depression. And again, women are almost 2 to 1 in terms of the frequency or prevalence of depression. But I think, whoa, I pushed the wrong button. One of the things that is also important to recognize is that younger people are actually more prone to depression than older people. Now, what is depression? I would be lying to you if I said I knew. I don't know. I do know that there are some things that are different about the brain of someone who is depressed. And one of the things that's probably characteristic of all people with depression is that if you look at the activity of the brain, there is an area near the base of the brain. So you know that the brain has 2 hemispheres and it's connected by this broad band of fibers called the corpus callosum. Well, if you look at it, that corpus callosum in cross-section, it looks like that. And just below it, near the front of the brain, is an area that's overactive when you're depressed. So the yellow and red means really active, blue means cold, okay? So what happens is that when you're depressed, that area of the brain is overactive. When you are recovering from depression, that area becomes less active. And what's interesting to me is even if you have a so-called placebo response, that area becomes less active. Now, that area of the brain is not just there in isolation from itself. The thing about the brain is every area of the brain is interconnected. But there are specific pathways in which the brain is connected, or the different sites of the brain are connected. And this area, which here says BA25, you forget the technical jargon, but that area that I just pointed out to you that was overactive in depression is this BA25. And it is connected to, it receives input from areas that are part of the dorsolateral prefrontal cortex, the frontal part of the cortex. And then it communicates with areas that are below the cortex that affect emotion as a whole, and things like energy and appetite, etc. Okay? So that seems to be a central component to what it means to be depressed, whether or not that's active. Now, everybody knows, you don't need me to tell you this, everybody knows that when you're under a lot of stress, you're more likely to be depressed, right? Well, it turns out that the hormone that is associated with stress is called cortisol. And cortisol levels in people that are depressed are generally much higher than levels that are present in normal controls. Not everybody has high cortisol levels, but in general they're higher. And what is also true is that when someone has high cortisol levels and you give them a very potent steroid, it will cause their levels to go down, so-called cortisol or dexamethasone suppression of cortisol. And so that's illustrated for you here. So if you give to normal controls this dexamethasone, it causes the cortisol levels to go to near zero. But in people that are depressed, you give the cortisol and the levels remain relatively unchanged. There isn't much change to it. So why am I going to all that detail? Because one thing that you're going to want to know is that there are consequences to having high cortisol levels. One of the consequences is illustrated here, and unfortunately, just because of the distance you are from the screen, it's a little hard to see, and I apologize for that. But what it shows is here is a neuron that has these dendrites, these extensions, and on the dendrites there are little spines that come off of it. Those dendrites and the spines that come off of them are the way that cells are connected to each other and how they talk to each other. So the more talk that takes place, the better the brain functions. When you have less sprouting, fewer spines, the brain doesn't talk to itself as well, and the cells actually become more vulnerable to dying. That's what happens when you have high cortisol levels, because it causes a compound called brain-derived neurotrophic factor to go down. And you need brain-derived neurotrophic factor to keep everything healthy. Okay? We're going to come back to this in a minute. In a few minutes. Now, one of the things that was always puzzling, and by the time I got out of my residency, we're talking 35 years ago, just a few years ago. One of the things that was controversial at that time was everybody was thinking about this dexamethasone suppression of cortisol levels and why they wanted to use it as a means of identifying who is depressed or not. But it turns out only about 50% of people suppressed and 50% didn't suppress. And so it wasn't something you could use as a diagnostic test. But no one really understood why there was the difference between the two until this study was done. And in this study, so it shows ACTH is what causes the body to secrete cortisol. So it's like a precursor. It's a way of inducing the cortisol production. And you see that the ACTH level is about the same on average between depressed and non-depressed. MDD means major depressive disorder, okay, for those who don't know that. And ELS means early life stressor, okay? So if you have an early life stressor such as childhood abuse, it turns out that your ACTH level becomes very high when you are placed in a stressful environment. So what this says, this helps explain why this dexamethasone suppression test was different between the two groups. So if high cortisol levels can be related to the brain cells essentially shrinking and atrophying, then one might predict that brain regions would do the same. And in fact, that is true. On average, when you're depressed, various brain regions are smaller in volume than when you're not depressed. By the way, the region that is larger, those are the cisterns that were in the brain that hold cerebral spinal fluid, and they get larger when the rest of the brain gets smaller. Okay? It's like the absence of brain tissue makes the ventricles larger. And I've always liked this slide because this was someone that I knew back in residency days. And she showed that over time, if you stay depressed for a long period of time, there is a progressive decline in the size of certain brain regions. Okay? Well, so we've shown that there at least is some evidence to indicate that the brain is different in people who are depressed. One of the things we know is that sleep is often impaired in people that are depressed. And if you look at this top drawing, what you see is that in depressed people, the deep stages of sleep, stages 3 and 4, are virtually absent. This may be a little bit exaggerated, but they're definitely decreased in terms of the total amount of time. The very deep stages of sleep are restorative. And so if you lose those, you don't feel rested. Okay? So what you see is instead of going into the deep stages of sleep, people quickly, latency is the amount of time it takes to get into rapid eye movement sleep. And what you see is that it doesn't take much time in comparison to normal controls, much less time for them to get into those rapid eye movement sleep stages. So there's more dreaming, but it's not as restorative. Okay, so how does depression affect your life? Well, we've talked about the diagnostic criteria. Those are real things. Those are problems that people have. When you can't get any enjoyment out of life, when you feel guilty about the least thing and you're kind of absorbed by thoughts about that, when your energy is poor, you can't concentrate, you're either gaining weight or you're losing weight, you're kind of restless and agitated, or you're so slowed down you're just hardly moving, and having suicidal thoughts. Those are very, very difficult things to deal with. But here's something to keep in mind. What's the consequence of that? Well, it turns out that this is a measure of how disabling depression is. Because there's such a large percentage of the population that have depression, and there are so many people who are unable to work when they are depressed, it turns out of all the psychiatric illnesses there are, depression causes more disability than any other psychiatric condition. Okay, so why do people get depressed? This is the $64,000, and probably now it would be the $64 billion question. But it has to do with genetics. It has to do with your biology at the time, environmental influences, and also psychological factors. And if any one of those could be a whole textbook, and we just don't have time to go into them in detail, but just remind you that that's true. When you're talking about a specific episode, and I deal with people who, on a daily basis, who are having problems with depression that's unresponsive. And over and over and over, I get asked this question: why am I depressed now? What's going on with me now that I'm depressed? And the answer is always the same: I don't know. I can't know. Even if I knew about all the specifics about what was going on in their life, I couldn't tell you what it is today that's causing you to be depressed. It seems like it's a balance between the resilience factors and these kinds of things. So if you have a family history of depression and you're experiencing some traumatic event and there's been a major life change and a significant medical problem, or you're on certain kinds of medicines or using alcohol and drugs, all of those things predispose you. But why you're depressed at one particular moment, no one knows. Now, in terms of the genetics of it, the best way to look at that is through twin studies. And identical twins have the same genes, and fraternal twins are like siblings. They don't have identical genetic makeup. So if you look at the difference between whether or not identical twins, if one of them has depression, will the other one have it? What's the probability of that? It's approaches 60% if you're talking about severe episodes of depression. If you're talking about fraternal twins, it's probably roughly half that. So there's a very strong genetic component. Once you get depression, some people have a single episode that lasts for weeks to months, and then it kind of goes away, and it may or may not return. A lot of people have more chronic depression. That is, they go from one episode of depression, maybe with a brief interlude, they have another episode, and it goes on and on. Those people who tend to have chronic episodes of depression are more apt to have had their first episode when they were young, a very strong family history. They tend to be anxious when they're depressed. They tend to be abusing alcohol, have life events that just keep going on and on and on. Having been physically or sexually abused as a child, the more episodes, the more likelihood of depression. If you've had one episode of depression, there's about a 50-50 chance of a second. If you've had 2 episodes, there's about a 70% chance of a third. If you had 3 episodes, there's a 90% chance of a fourth. And low socioeconomic or educational status, or being old like me, also predisposes you. So how do we treat depression? Now, most of you probably want to hear a lot about this, and I will answer questions about it, but I'm not going to go into a lot of detail about how we can treat right now, because we could spend many hours talking about it if we wanted. But it can be by drugs, it can be by psychotherapy, or what we now call neuromodulation approaches. Now, neuromodulation approaches actually began with electroconvulsive therapy, which is still used, by the way. And it's it's still one of the most effective things that we can do to treat depression. It's something that is the most invasive thing that we do to try to treat depression, or virtually the most of it, invasive anyway. And so we don't like to use it as first-line treatment, but it's something that can be used. Phototherapy, have any of you bought boxes of lights that you stay in front of for hours every day? Some people do that, particularly up in the north, where seasonal affective disorder is much more common. You know, here, as long as you go outdoors sometime, you're going to get enough sun, you'll probably be fine. But when you live up north, you don't get out in the sun much, and seasonal affective disorder is common. Transcranial magnetic stimulation, we're going to talk about more specifically later. Direct current stimulation is intriguing because it's something you could do by yourself. The problem is it's not clear that it actually works. So vagal nerve stimulation is something that's very invasive, where you put electrodes to the vagus nerve that stimulate going into the brain. Sleep deprivation is not something that I get very many people willing to do, but as you're starting your antidepressant, if you'll stay up for 27 hours, you'll get a little bit of a kick and a boost, and you'll get better a little bit faster. Have anybody ever stayed up for 24 hours? How many times? Yeah. Yeah. Early morning, right after you've been up for 24 hours, you get a little bit of a boost. It doesn't last long, maybe a few hours at most, but you get a little bit of a kick. And that's what this is all about. And then deep brain stimulation is the most invasive thing that we can do, where you actually put electrodes down into that area of the brain that we talked about was overactive. But that's only done in a very rare situation. I have actually never treated anyone with that. It would be interesting to see the response, though. There are a whole bunch of different kinds of drugs and different categories of drugs. We could spend hours talking about this. I just want to make sure that you know that there are different kinds. And so if being treated with an antidepressant just doesn't mean that you have been exposed to everything that's possible. How do antidepressants work? Well, here's the key. I've already told you how they work. They increase brain-derived neurotrophic factor. All known interventions, ECT, transcranial magnetic stimulation, and medications increase brain-derived neurotrophic factor. That seems to be the common mechanism. And so if we go back to this illustration that I showed you before, in the third section, antidepressants, this is an initial step, but they eventually produce brain-derived neurotrophic factor and increase sprouting and growth, and then better survival of the neurons. Okay. Now, when you're being treated for depression, it's important that there are key principles that are followed in the process. One is you got to know what you're treating. So the first thing you're going to do, if you come to see me, for instance, the first thing that I'm going to do is I'm going to spend a lot of time figuring out if you actually have depression. And if you don't have depression, then I'm not going to try and treat it as depression. But most people, by the time they get to see me, the diagnosis is accurate. The second thing is dosage and duration do matter. It's not just being exposed to a drug. You have to have the right drug at the right dose for the long enough period of time to see the benefit, right? Believe it or not, if you leave the drug on the shelf, it doesn't work very well. Just one of those things to remember. When possible, I try to give the drug in a single daily dose. Why do I do that? Well, I can tell you from personal experience. I, many years ago, injured an ankle, and I have pain on a daily basis in relationship to it. I can't remember to take medicine for that twice a day. I mean, it probably less than 50% of the time can I remember that, even if I'm in pain. And it's the same thing for depression. If you ask people to take it once a day, and it's safe to do it that way, it's going to work better that way. One of the things that I notice when people get referred to me is that sometimes the problem really is that someone gave up too early. They tried a couple things, they made a couple minor dosage adjustments, but they didn't see the thing to the end. So the important thing is you gotta be tenacious. You gotta keep working toward an end of them being in full remission of symptoms. And you don't give up until you get there. As you go through the process, you may have to add medicine, you may have to switch to something. It's always better to add first, because switching generally is less effective than augmenting. And then one of my tricks is when all else fails, prescribe something that you can measure the blood level of. And oftentimes that's useful. When you're talking about depression, just so that we're all on the same page, here's someone who's normal, they go into an episode of depression, and then you start treating it. Acute treatment results in them going into remission. Remission means their symptoms are mostly gone. If they remain in remission for 6 months, we say that they've recovered. If they reach remission until they reach recovery, it's called continuation treatment. And after recovery, it's called maintenance treatment. If they have a recurrence of the depression while they're in this continuation period, you say that they have relapsed. But if they have reached recovery and they go into depression again, you say they had a recurrence of their depression, just so that we're all on the same page. Now, mathematical modeling can sometimes be very useful. And I discovered this paper in 2015, and I spent a fair amount of time trying to learn more about how to use this. And what they did was they looked at about 300 people who had all received the same drug, and then they had measured at various time points their response to that drug. And then mathematically at the end, we're talking about at this point, they said which patients, and this was using a mathematical model, which patients changed over time in the same pattern. And so they were able to identify some specific patterns. And what they found was there are some that respond very quickly. There are some that respond in sort of intermediate ways, and all told, that's about 45%. And then there were 3 groups, some that started with higher starting points. They were more depressed overall, and some intermediate and some lower depression, but they all had relatively flat periods. So you might even say that you could lump all of those together. And that's roughly half, a little over half of the patients. What that tells you is that actually there are a lot of people with the first approach at treating that don't respond very well. And even more importantly, this is the study that I just talked about had about 300 patients in it. This study had over 3,000. And it was done, a consortium of investigators across the country, but it was headquartered at UT Southwestern. It was done in the early 2000s. And what they did is they placed everybody on citalopram, which is also called Celexa, which is a very commonly prescribed selective serotonin drug. And they looked at how many went into remission, what percent went into remission. It was a little bit better than a third. And then those that didn't respond to that, they put into the second level of treatment, and they either added something or they switched them to something else. And now we're talking only about a 30% went into remission. And then if they didn't respond to that, those that didn't respond were placed into a different set of treatments. And here, only about 14% went into remission. And then finally, they had other switches that they did, and they had even a smaller percentage. So what happens is that we're talking about 4 levels of treatment. This is pretty intensive, aggressive management. And starting with 100 people, you end up with a third of them that did not go into remission at all. And that is the group that I work with on a daily basis. Okay. Now, these people that are refractory to treatment, they can be refractory for a variety of reasons. They may have morbid psychiatric or medical conditions. They may have not had the right drug. They may not have been given it for adequate dose or duration. They may not have been adherent. Or they just may have very severe illness that didn't respond very well. So how do you protect yourself from getting depressed? And by the way, we're going to go over some information here, and as I do this, these are ways to help yourself. I do not mean to imply in any stretch of the imagination that even following these principles that you can always prevent yourself from going to an episode of depression, but it will help, okay? So there is a book called Resilience, the Science of Mastering Life's Greatest Challenges, and I learned about this book from a guy by the name of Dennis Charney, who was one of the co-authors. And Dr. Charney is the dean of the Albert Einstein College of Medicine. And he is someone who is very well published in the field of the neurobiology of mental illness. And he published what he calls the Resilience Prescription, which is basically a summary of this book. And this is his resilience prescription. First of all, have a positive attitude. Be optimistic. Now, some of us have an easier time of being optimistic because we were born that way. But all of us can learn to be optimistic. So you have to practice. You have to look at things from the most positive perspective. but be optimistic. The second thing is to do cognitive flexibility and cognitive reappraisal. In other words, look at things from the perspective of what this means to you. Its perceived value. You know, there are times in my life when I have not been given promotions or jobs that I thought I would love to have had. And there are a variety of reasons why that didn't occur. But the thing is if you take the perspective of, okay, that didn't work out, what can I learn from this experience that's going to help me to know how to manage another situation, the next job that I go for, right? That's how you should be thinking about this. What can I use out of this that's going to give some meaning or significance to me? And one of the most important part of knowing about meaning and perceived value is you have to embrace a moral compass. Now, what does that mean? Well, part of my moral compass is my Christian faith. I can feel very comfortable in this particular building because the church that my wife and I attend met here for several years and just stopped meeting here about the time COVID hit. But having a core set of beliefs that provide some purpose and significance to your life and living your life according to that, that's a way to be resilient. So this terrible thing happened to me. I don't know why it happened, but I know that I am going to grow somehow through this process. If you know somebody who's resilient, talk to them. Ask them to be your mentor. Find a way to learn something from them. All of us have things that we're afraid of. When we're afraid of something, instead of allowing it to overwhelm us, you've got to find a way to face it, a way to engage it, and to overcome it. What follows from that is developing active coping skills. So my wife and I used to do a Sunday school class on parenting, and we came up with 3 P's, being purposeful, persistent, and prayerful. And the point of that is being purposeful. That's really the most important part of that, is that if you pay special attention and make it a point to engage in coping skills and learn coping skills that are going to help you go forward. All of us need a social network. And, if you have something that you are doing on a regular basis that you enjoy doing, find other people that are doing that. Link up with them. Move forward. Have a movement or join a church. Do something where you're doing things with other people that you can have a social network with them. You have to attend to your physical well-being, and Patsy, I attended one of her courses. It's probably 15 years ago. And it wasn't that I didn't know to exercise, but it has spurred me on at times. But it's not only your physical health, you have to pay attention to your mental health and your skill set, having hobbies and so forth. you need to train in these things. You need to prepare yourself. And then finally, all of us have weaknesses, but we also have strengths. And you got to learn how to foster your strengths. So all of those things can be helpful. Now, the one thing that I dread most about my job is helping people who are struggling with wanting to take their own life. And the few times where my interventions failed, it was devastating. And that was with people that I knew some, but I didn't know them intimately. But there are probably many of you have had people that were important in your lives who took their life. And I think that's the saddest outcome of depression. That's why it's a life-threatening illness, is because some people do this. And here are the stats direct from the CDC. Over the last 20 years, the number of people taking their life has progressively climbed. There's a little bit of a dip here, but this is pre-COVID. This is the line for men, this is the line for women, and that men as a whole are much more likely to take their life than women. Women actually attempt it more frequently, but men take their lives. They use more lethal means. And I'm sorry that you can't read this, but basically what you see in green are, we're looking at 10 leading causes of death by age group, and the ones in green are those of suicide. And what you see is the risk of suicide is not even hardly measurable before age 10. From 10 to 34, it's the second leading cause of death. It drops somewhat from 35 to 55. And after age 65, it's not a leading cause of death just because everything else is more likely to occur. Overall, it's the number 10 reason why people die. By the way, the suicide rate is roughly 20 per 100,000 per year. If you multiply that by the average lifespan, you ultimately end up at somewhere around 1% of people kill themselves. This is, I think, tells the tale a little bit better, because what it says is that, again, the risk of women committing suicide is much lower. Men are much more lethal in doing it, and the people that are the greatest risk are men over age 75. Men who no longer have a profession. They may be having some financial difficulties, health difficulties. They've lost their spouse. Their life is closing in ahead of them, and they no longer have purpose and significance to their life. Those are the ones that are at greatest risk. And I can summarize all this by saying, to prevent suicide, you've got to engage people and get them engaged. That's the best way to say it. Okay, so what is there ahead? We've talked a little about what depression is. We've talked about what types of things are done for it and the risks associated with it. Beginning in the 90s, they began doing studies where they gave ketamine intravenously, And when they gave ketamine intravenously, they found it made people psychotic for a little while. They may have had some dissociative experiences. But what happened ultimately was that they learned it could help depression. And what you find here is depressive symptoms go down, and it's hard to read, but this is the first 2 hours. This is day 1, day 2, day 3. You see by day 7, it's disappearing. So you get a very good effect, but it lasts a short while, and you have to keep giving it over and over again. The problem is that because it makes people psychotic or potentially psychotic for a brief period of time, you want to do this in a controlled setting. Well, it becomes cumbersome to watch somebody for a couple hours after they've received either an infusion or, as we deliver it in our clinic, as a nasal spray. It just becomes too cumbersome to do that 2 to 3 hours on a daily basis for indefinitely. So we do it twice a week for a month, and then once a week for a month, and then give up, usually. So that is one thing that's out there, and some people do get benefit from it, but the problem is it's not a good long-term solution. A better solution, in my estimation, is something called transcranial magnetic stimulation. And in this, you put somebody in a comfortable chair. Here's the magnet. You put a magnet on their head in a specific place. We have to identify where that is. We have to identify how much stimulation to give. And then you put electricity pulsed through the magnet. By physical properties, it causes an electromagnetic wave to go into the head. And so that's what that says, and that causes neurons to be activated, and you get neurotransmitter release, and you ultimately get increased brain-derived neurotrophic factor. It can be focused over specific areas because of the configuration of the figure 8 coil that we use. But if you remember this, well, we can't get the stimulus all the way down to this overactive brain region, but we can hit this area up here, and because it's connected to this area here, we get an antidepressant effect. Now, it takes a lot of treatments. Generally, we treat 36 times over a period of 9 weeks. But the treatments themselves only last a few minutes. By the time we get you in, get you set up, and gather some brief information and everything, you're probably talking a 30-minute commitment. But basically, it's a lot of times. And just like you saw with antidepressant treatment, you get the same kinds of response. This is the same analysis where which patients respond together. What's different is the non-responders, instead of being close to half, it's like 10%, 11%. 20% are in this range, and 70% are in those groups. So we've covered a lot of different kinds of things, but any questions? Yes?
Hicks, how do you measure the severity of the depression other than verbally speaking with the patient?
Okay, I'm going to give you testing. No. Oh, there it is.
My question is, how do you measure the severity of the depression other than verbally assessing the patient?
There is no other way. Okay? Now, we use a scale, so we ask the same questions. We actually, the Patient Health Questionnaire 9, PHQ-9, is a series of 9 questions that are rated from 0 to 3. And it's supposed to be a self-rating, but we usually ask the questions so that we can interpolate a little bit, interpret what they're actually saying. Because some people over-report their symptoms, some people under-report their symptoms, and we try to pull that information out. Yeah.
You see, in some depressed people, their depression comes out as anger and behavior.
Yeah, so the question is that for some people, the depression comes out as anger. And, that's the old psychoanalytic thought that depression was anger turned inward. And there probably is some truth to that. Certainly, some specific people are angry because are angry at circumstances, and that fuels their development of depression. But I think it's too far to state that all depression has to do with anger. Yeah. Yes. Why don't we start here?
Yeah, what is the relationship of anxiety to depression?
That's an excellent question. So, they don't always go hand in hand, but they usually do. And one of the things that some of the studies that I've been involved in have clearly demonstrated is people that are very anxious and have high depression scores are the ones that are least likely to respond to treatment. But for instance,
Are they treated similarly, the same way?
Not exactly. Antidepressant therapy or transcranial magnetic stimulation or ECT will help control the anxiety as well as the depression. But you can specifically target anxiety by using benzodiazepines, Valium-like drugs, or buspirone, or other drugs. But antidepressants have some anti-anxiety properties, more of a preventative for anxiety than I'm feeling anxious, I'm going to take this drug and it's going to make it go away. Yeah, I think there's some questions up. This person.
Coming from kind of the opposite side, I was wondering about depression with Alzheimer's.
So it's very common that in the early stages of Alzheimer's disease, there may be depression or anxiety or both, sleep disturbance. It oftentimes is difficult to distinguish if you don't carefully assess their cognition when you're evaluating them. And in fact, there is a controversy that is going on in the psychiatric literature right now that says that people who take benzodiazepines, Valium-like drugs, that they are more likely to develop dementia. My interpretation, and I think the majority of people now agree with me, is that what is actually happening is that the people who need benzodiazepines are the people who are in the process of developing dementia. That is, it's not a cause of dementia, it's something that happens when people are in the process of developing dementia. They have a need for those kinds of drugs alleviate their symptoms. Yeah.
I had another thought as you threw up the risk factors up there, so thank you for your work at the clinic, because as I was looking through those risk factors, I was like going, wow, I bet a lot of our patients that come in have several of those risk factors. Thus, they need some mental health intervention sometime.
Yeah. You know, risk factors are just that. They suggest a vulnerability. They don't suggest that it's going to happen, but it definitely a vulnerability.
Do you see that either, people who are either, and this is my source, drug abuse leads to depression, or depression leads to drug abuse? I mean, or alcohol abuse, or any of that? Which way does that normally go, or is there even a determination?
Alcohol is a depressant. It does lead to depression. There's no doubt about that. But it's also true that a lot of people try to self-medicate with alcohol. So it's one of those things that we're never going to know for sure one way or the other, and it's best just to make sure that if somebody is depressed, that you're addressing their alcoholism as well as their depression.
Do you really think that the incidence of depression is higher in women than in men? Or is it just underdiagnosed in men? Because if you look at the suicide rates, men are much more apt. The data speaks for itself.
Yeah.
So when I see that depression is more common in women, I think my female patients are, because I'm a gynecologist, I only see females, but they're more apt to tell me I'm depressed.
Yeah.
And they're more apt to get treated, whereas guys may drink it away, try to drink it away, or do other things. So your thoughts on that?
I do think that men are less likely to get depressed. I think there are enough epidemiologic studies to suggest that that is true. However, the reason for the difference in suicide rates is that men choose more lethal means. Men shoot themselves, they hang themselves, they're less likely to overdose with drugs. Women primarily overdose with drugs, and not knowing how much it's going to take, and therefore it's not successful.
The other thing, looking at the suicide rates, and obviously suicide is rare, thank goodness, in preteens,
Yes.
10 to 14, but the suicide rate in preteens has tripled over the past 15 years. Can you give us some thoughts on why that's happening and what we can do as adults?
Yeah, so let's get back to those resilience factors.
Yeah, I love them.
Yeah. When I saw Dr. Charna give a presentation of them, and I've sort of latched onto them since. Core values and the need for core values. These days, there are fewer people who really have those core values. And I think that that's the problem.
I wondered if there's a clinical reason for bipolar, is it genetic or?
So I stayed away from talking about bipolar disorder for a reason. One is it is an overused diagnosis right now, by far. If I were to take half of the patients who come to me with a diagnosis of bipolar disorder, they cannot describe a single manic episode. And by definition, that means they're not bipolar. And so it's an overused diagnosis, and it is a popular diagnosis. And so, if somebody says, well, I have all these mood fluctuations, okay, that doesn't mean that you're bipolar. Bipolar disorder, by definition, means that someone has had a sustained period of increased goal-directed activity, being hyperverbal, decreased need for sleep, euphoria, and/or irritability, and they get themselves into circumstances with unrecognized consequences. So they spend too much money, they get involved in relationships that destroy their marriage, all those kinds of things. That's mania. And if it's mild, we call it hypomania. But if you haven't had one of those episodes, you're not bipolar. Bipolar disorder has an even stronger genetic component to it.
I was going to ask because I know someone, and his family says from a baby, he started out being aggressive and then so sweet, and they just couldn't control him.
Yeah, and that doesn't necessarily mean that they were experiencing a manic episode. A manic episode is a discrete, it has an onset, it has an ending episode.
Yep.
And if it doesn't fall that way, then it's probably not an episode of mania.
Well, I know the person I know, they medicated him, and he hated taking the medicine because he said it made him feel he didn't have any control anymore.
Yeah. And that's the thing, is bipolar disorder is a lot more complicated to treat because you have to not only treat the depression, you have to kind of keep the lid on it to keep them from becoming manic. And the patients that I have that are truly bipolar, it's like having a tiger by the tail. It's tough.
Jekyll and Hyde.
Was this awesome or what? Oh my goodness. Paul, this is great. And I took a picture of your resiliency prescription, a positive attitude, remaining in the inner spirit and trying to get our ego out of the way, and cognitive flexibility and embrace a moral compass. What are our values? Finding a resilient role model. I seek these people out and I stalk them, okay? Face your fears, don't avoid them. Develop active cognitive skills. Establish and nurture a supportive social network. Join Altrusa International Temple, okay? Attend to physical well-being and train regularly in multiple areas and recognize your strengths. Don't just focus on the negative. This is living well aware, okay? And this is what we all ought to be doing. And everybody, you guys attending this series and you helping us out. So we're going to keep having programs that are going to help us be more resilient. Right, Sherry? Yes. All right, Sherry, and I know several of y'all are registered for my Living Well Aware in Cedar Break and for the webinar series that's coming up, and if you have any information about it, I've got more information because it's all about us being more resilient and taking life on. So, again, Paul, thank you. Thank you.